With that, we will get started. Please feel free to type in any questions or comments that you have in the chat box at any time. We will have time at the end of the webinar for your questions and have a further discussion at that point. Tara and Sasha, I'll turn it over to you.
Okay, thanks so much, Helly. So we want to start by thanking all of you for being here today. We know just how busy life is and how difficult it can be even to find an hour to attend a webinar. So we do really appreciate all of you being here. We're going to start with some housekeeping. So the slide deck will be shared with you shortly following the training. The webinar will be recorded and posted on the RGP Toronto YouTube channel. So if you have colleagues who you feel would benefit from this session, please let them know that they can find it there. Please type your questions related to the content into the chat. As Helly mentioned, there will be an opportunity for questions and answers at the end of the webinar. We also do recognize that there may be some case-specific examples that require resolution. However, unfortunately, we won't be able to address these cases today just because of time, and we do always encourage you to connect with behavior supports in your settings or regions as well. So let's talk a little bit about our goals for today. We're going to broaden our understanding of depression and anxiety-related disorders. We will identify the signs and symptoms of both, and then we're going to talk a little bit about those really practical supportive strategies and interventions that you can apply when caring for your patients, clients, or residents. So now we'd like to get to know a little bit about you. So we are going to launch a few poll questions. So we'd love to know what your role is within your organization. So we'll give you a moment just to answer this first poll. Okay, so 2% of us are personal support workers, 22% are nurses, 12% are occupational therapists, 16% are social workers, we've got 6% of folks who are recreation therapists, 8% PRCs, 6% administrative, and 29% other. So if you'd like to pop what your role is, if you answered other into the chat, that would be great. And we'll move on to the next question. And we would love to know how many years of experience you have working in the field. So please take a moment to answer this poll question. Okay, so the results are in 17% have 0 to 5 years of experience, 13% have 6 to 10 years of experience, 19% have 11 to 15 years of experience, 15% have 16 to 20 years of experience, and 35% of you have 21 years or more of experience in the field. And, you know, whether you've got a year under your belt or 40 years under your belt, we all have so much to share, so much experience. We're all looking through very different lenses, and really, you know, the experts in our particular roles looking through our specific lenses. So we do encourage you to please share anything you're comfortable with in the chat at any point in our webinar today, and again, as well as ask any questions that you have. So next question, please. And we are wondering if you have attended any of our previous webinars in this series. Okay, interesting. 29% have and 71% have not. So welcome to our new friends and welcome back to our old friends. If you would like to check out any of our past webinars, those also live permanently on the RGP of Toronto's YouTube channel. Okay, thank you so much. So I'm going to pass it over to Sasha, who will take us through our first Menti poll.
Thank you so much, Tara, and welcome everybody. So one of the questions I want to ask, and I can see that we have so much experience in the room, so I am assuming we're going to have some great answers here. But if you could please go to menti.com and enter the code that you see at the top of the screen, and please answer the question, what are some common causes of depression?
All right, I was concerned this might happen. We have been having some technical issues with Menti when it's embedded in PowerPoint, so bear with me, everyone. I'm just going to try to, there we go.
All right, so it is working. I see it on my end, so we've got some great answers coming in. So I see some things like trauma, there's loss of a spouse, major life changes, looking at unexpected life changes or changes in the environment, grief, definitely. There's biological causes of depression. So I know that there are probably a ton more answers. I'm not sure if it's maybe Menti that's freezing, but I would like to say, I think that, oh, there we go. Lots and lots coming in now. Absolutely. Okay, so the wonderful thing about Menti and this kind of word graph here is that the ones that are larger in size are the ones that are answered most often. So we can see that isolation has been coming through as a major one, trauma, grief, loss. These are great. So loss of purpose, chemical imbalances, health concerns, brain injuries. So yeah, we have so many different areas. We're looking at biological, we're looking at, genetics, we're looking at history and brain chemistry, we're looking at life circumstance and environmental circumstance. So there's just so many different things that can unfortunately lead to someone experiencing and living with depression. So I want to thank you guys so much. There's so many good answers in here. And to say that you are right. All of these answers are definitely things that can lead to the diagnosis of a depression or to some of the signs and symptoms of depression. So I think it's important for us to really first look at what are some causes and some risk factors. So you named quite a few of them. So there are various different areas in which we can kind of envelope these specific causes and risk factors, looking at genetics. So individuals with a family history of depression may be more likely to develop depression. For those of you who do extensive research in the area of mental health, we all know that it's still an ongoing area for more needed data and research. So genetics is considered to possibly be a risk factor. Personal history, so older adults who lived with depression earlier in their life, they actually may be higher at risk to develop depression later on in their life. And I think it's important for us to remember that depression isn't always a non-stop experience for somebody. They can go through transient episodes. So you may have a depression earlier on in life that may subside, and then later in life, you may again have another episode of depression, and you may be at higher risk if you do have that previous circumstance. Brain chemistry, so people who live with depression might have some sort of chemical imbalance we talked about. Looking at neurotransmitters, things like serotonin have been deeply researched. There's still no definitive proof, but there is some efficacy in terms of treatment that shows that maybe serotonin may have something to do with it. And then also trauma or stressful life events, looking at loss. We mentioned a lot of loss in the Mentee poll. Any strenuous sort of relationship or various other stressful situations can have the capacity to trigger depression or a depressive episode. Another thing is that there are a lot of different myths out there about depression, but it's kind of nice to really look and focus on some of the facts. First is that major depression is not more common in the elderly, but it is more difficult to treat. And ageism can play a role in normalizing these signs and symptoms of depression. So it's very important for us to be a little bit more objective and not look at it as a normal part of aging. Often, depression is accompanied by anxiety in the older adult. And this is, sometimes we can often overlook anxiety as a manifestation of depression, but the two can go hand in hand, which we often see not only in the older population, but also in the younger population as well. So usually if there is a depression present, you might see some of those signs and symptoms of anxiety. And they kind of go into this into a cycle. You'll see some of those anxious behaviors. And so when Tara goes through anxiety later in the webinar, you'll often see that those are accompanied with depression as well. So depression can mask or be masked by physical problems. So we know a lot about, in terms of when we speak about the older population, we look at delirium, dementia, and depression always together. These three can kind of mask because they have similar signs and symptoms. So we think about, pain, fatigue, and other medical symptoms that cannot be explained by any sort of physical test or physical cause. These things can actually be due to the depression. And depressed older adults can become, somatically preoccupied. So they start to complain of many physical symptoms, and there isn't any clear cause for those symptoms, for those physical symptoms. And it can be often, due to the depression, it's actually causing those somatic complaints. So it's important, even though we are looking at maybe a stomach ache or headaches, and we can't seem to, subside those symptoms with a Tylenol or with normal medications, we may have to look deeper that it might be an underlying depression that's causing that. It is often missed or misdiagnosed in older adults because, again, these are being mistaken for everyday problems of the aged. We need to understand that it is a very real experience for those who are living with depression, especially those who are older adults. If you think about all the things we mentioned in the Mentee poll, there are a lot of losses that comes with age in terms of losing friends, losing spouses, losing independence, sometimes losing your home or other things, especially for those who are going into long-term care facilities or other areas of long-term living. Those are all losses that can definitely provoke or precede a depressive episode. There's a direct link between the number of episodes untreated and the chance of recurrence. So this kind of looks at if we're not treating the depression that is underlying, obviously they're more susceptible to having further episodes of deeper depression and more severe cases of depressive episodes if it's not being treated medically or with counseling. And finally, we know that there is a link between cognitive loss and depression, and there can be some diagnostic overshadowing between dementia and depression. And oftentimes it may be assumed that it's dementia in the older adult versus depression. So it's very important for us to really look into all of these different complaints. And we want to also understand that some people who do have depression may experience some cognitive complaints as well. So it may be that their cognition is decreasing due to the depression and not the other way around. So other signs and symptoms of depression, we can look at the onset of depression that often occurs during adolescence, but it can occur later in life as well. So even if someone does not have a depression earlier in life, there is still the possibility that they will develop a new depression later in their life as well. So women tend to feel sadness, worthlessness, and guilt, while men often feel angry, irritable, and anxious when depressed. It is also important to know that women tend to be highly more susceptible to depression. There's also symptoms such as social isolation and withdrawal that can compromise their interpersonal relationships. This can look like things that they are no longer eating, they are no longer sleeping well or sleeping too much. They're no longer taking pleasure in the activities that they used to take pleasure in. They are avoiding their social contacts, or they're avoiding family, and they're avoiding the things that they used to love doing. So we can really look out for some of these different signs and symptoms in our residents, clients, patients, and really look at how we can kind of step in and do the appropriate assessment. It is also important for us to understand that in some cases psychosis can occur. And if that is the case, we need to follow, the high-risk protocol for psychosis, depending on what your policies are within your facilities. And if you are supporting someone who is showing signs of psychosis, it is important to ensure that they are closely monitored and that they are getting their treatment that they need. Sticky caps is basically a tool that you can use to kind of look at, are these signs and symptoms present in the person that you're caring for? And if you do see that these signs and symptoms are there, then you may want to either do a depression assessment scale, whether it's the GDS or looking at any sort of depression scale, Cornell, that you do in your facilities, and looking at further investigation and maybe even involving a psychogeriatric team to help you with that assessment and diagnosis. So Sticky Caps looks at sleeping at too much or too little, the interest in activities are decreasing. If they have this guilt that is very palpable, they're talking a lot about feeling guilty, their energy is depleted, their concentration and memory problems are either more severe or different from baseline. They have appetite increase or loss. They may even have some psychomotor problems. And obviously, if they're talking about suicide, and that's definitely something that you would want to look further into and make sure that the person is getting the help that they need. The good news is that, depression is quite prevalent, especially in the older population, but there is so much that we can do to help support our population of older adults. We can modify the physical and social environment to make it happier or brighter. There's so many different types of therapy that are not medication related, although medication is still obviously an approved way to manage depression. But looking at things like light therapy and relaxation therapy, self-help and self-affirming interventions, and computerized therapy, looking at eating well and avoiding alcohol, finding meaningful activities. And if the person's behavior is putting either themselves or others in danger, it is really important that we consider seeking help. We want to find out if they have a plan in place, and knowing that by asking the person if they do have a plan, that we are not placing the idea in their mind. We're simply trying to see what is the level of risk and make sure that they have this appropriate amount of support. Other supportive strategies, we can present tasks in small steps, and we can encourage the person to do what they can at their own pace. We also want to allow them to have reasonable rest periods, because we need to know that not all people, especially older adults, want to be going to the extent that they used to in their earlier years. They may want their times to relax and to just take that time and moment of peace, and that's okay. It's also good for us to kind of look at the behaviors that they're showing, or look at some of the signs and symptoms that they're showing, and really kind of think, is this something that is related to a possible depression? Or is this just maybe them kind of slowing down, wanting to take a little bit more time, and just ensuring that we're looking at all the signs and symptoms as they are individualized to the person who's experiencing them. We want to talk to them and express their concerns by being good listeners. We want to actively listen. We want to watch our bodies and watch our body language. And we really don't want to take things personally if they're angry or irritable. We have to understand that these feelings are very real, and they're strong. They're very strong feelings. And we want to give positive reinforcement and provide choices. We want to give them the choices to do things that they love to do, and just kind of monitor how the reactions are towards those different activities. We want to provide them with structure to reduce anxiety, and assist them to see that they are unusually sad or blue. And we want to kind of ask and question that. Why are you feeling sad? What is happening in your life? And allow them to express those concerns. The other thing we really want to make sure we're doing is explain how depression affects people. We want them to understand that this is something that what they're experiencing is a normal occurrence living with this depression. So things like appetite and sleep and lack of energy and interest and sad feelings. And this will help them to maybe understand that their mood state is due to illness, and they may actually be a little bit more okay with taking any of the treatment that you may offer or any of the help that you're offering. We want to also express that antidepressant medications and talking therapies are the most common treatments, and they do have high efficacy in terms of treating depression. And I want to pass it along now to Tara, who will take us through anxiety.
Thanks, Sasha. So we're going to start off with another mentee. So I'm going to ask you to please head back over to www.mentee.com. And this time you'll enter the code 46130808. That code is at the top of your screen as well. And what we'd like to ask you, keeping in mind, of course, that your answers in this mentee poll are completely anonymous, we'd like to ask you when you personally have experienced times of anxiety in your life. So we'll give you a moment to please enter your responses. I am just going to double check that this is working. There we go. Okay. So far, our most common responses are life changes, absolutely, and new job. That is definitely an anxiety-ridden time. The pandemic, lockdowns, yes, labor, exams, interview, meeting new people, speaking to people, social situations, stressful work, financial problems. These are coming in faster than I can keep up with. I love it. Transitions, yes. So we'll just give it another moment. When it stops moving and we know it's slowing down, we'll start to talk a little bit about what we see on our screen in front of us. So as we're slowing down, I want everyone to take a moment and have a look at these really honest and human responses we have on the screen in front of us. Looking at a lot of these answers, I'm sure most of us can relate. And what that really helps us remember is it is completely normal and human to experience anxiety in our lives. Throughout our life journey, we are going to endure many situations, both positive and negative, that can be anxiety provoking. And the reason I really want to start by talking about that is because I think it's really important for us to remember that there is a difference between experiencing times of anxiety and anxiety-related disorders. It's when the anxiety persists, usually for about 6 months or more, that we start to look at the possibility of an anxiety-related disorder. Because again, taking one last look at this screen in front of us, we can really see just how common and how normal it is to experience anxiety. So thank you all so much for taking the time to respond and sharing your experiences with us. And now we're going to move on to talk a little bit about different anxiety disorders. So for the purpose of this webinar, we're just going to focus on these 5 types of anxiety disorders. And while we recognize that, of course, there are many different anxiety disorders, these are the most common amongst the population that we're supporting. So we're going to talk a little bit about generalized anxiety disorder, which you'll hear me refer to as GAD moving forward, specific phobias, panic disorder, agoraphobia, and social anxiety disorder. So let's start with GAD and talking a little bit about some of the signs and symptoms that we see in GAD. So we know that people living with this anxiety disorder may be feeling irritable or sort of keyed up or on edge. They may be excessively sweating, feeling lightheaded or out of breath. They may be taking frequent trips to the bathroom. They may be feeling tired a lot or finding that they are really tiring easily. And they may be reporting headaches, muscle aches, or stomach aches. So, what we need to remember as well is that these signs and symptoms can also be signs of medical conditions. So GAD is definitely more likely if physical health issues have first been ruled out through history and physical exam and testing. So it's important for us to do that before we start considering GAD. So what can we do? What are some of these really practical supportive strategies that we can use to support somebody living with generalized anxiety disorder? So I'm going to start with exercise. Exercise is one of the best supportive strategies for folks who might be living with depression or an anxiety-related disorder. We know that it's highly effective, and the reason for that is exercise or movement of any kind causes the brain to release endorphins, which naturally elevates our mood and helps to relieve anxieties. And it's a tool that we have in our toolkit with almost every person we support. Reassurance. So, reassuring the person that everything is okay and that there is support available to them. Sometimes just listening and offering reassurance can help the person with anxiety to feel calm and comforted. Healthy eating. So there is scientific evidence that what we eat has a direct impact on our mood, which is actually quite interesting because if you think about yourself and if you've had, a stressful or maybe not a great day, what do we usually turn to? Do we turn to the junk food or do we turn to the salad? And if you're anything like me, you probably turn to the junk food. And that's okay. It's all about balance. But really the idea is sort of like this 80-20 rule. So 80% of the time, encouraging the person to eat a healthy, balanced diet and eat nutrient-dense foods regularly. And then 20% of the time, really indulging in the food that we love to turn to sometimes. We know that this healthy eating, again, does have a positive effect on mood and quality of life. Deep breathing exercises. So deep breathing naturally calms us and slows our heart rate. And we're actually going to have an opportunity to practice this in a moment. Relaxation training. So relaxation techniques are easy to do and they're highly effective. What they are doing is they tell the person's fight or flight response that everything's okay. So they calm that sympathetic nervous system down. Meditation. So it does take practice. It's not so easy to do all the time, but it is proven to be a really effective support for managing anxiety. And mindfulness. What mindfulness, does is it really helps us to be present in the moment and therefore can really help us to prevent any worries about the past or the future. Thinking about having a supportive social network. So having a safe place for the person to share their worries can be really helpful in assisting them to cope. Oftentimes, when it comes to somebody living with anxiety or depression, without that supportive social network, they're just keeping it all bottled up. They may be embarrassed or afraid to share how they're feeling. And so really encouraging the person to do so can help them to open up and help them to feel safe and comfortable with sharing. And then group-based therapy. So there is more evidence for group-based therapy. So for example, group CBT for anxiety disorders than there is for support groups. But support groups can also be a highly effective strategy because what that does is it brings people together with this likeness factor where everyone in that group is experiencing the same thing. And that in and of itself can often be really therapeutic. And then thinking about the treatment. So we do know that some people living with anxiety may require pharmacological intervention. However, we also know that this is on a case-by-case basis and should be discussed with a physician. So now we are going to go through a deep breathing exercise together. So I'm going to ask everyone to just find a comfortable position. So we know, as I said, that deep breathing naturally calms us down. It's really one of the best ways to lower anxiety and stress in the body. So what I'm going to ask you to do now that you're in that comfortable position is I'm going to ask you to take one hand and place it on your stomach just below your ribs. And then I'm going to ask you to take your other hand and place it on your chest. After you've done that, I'd like you to take a deep breath in through your nose. As you do that, I want you to really let your stomach push your hand out. Your chest shouldn't move at all while you do this. And then I want you to take a deep breath out through your lips, through your mouth. And as you do that, I want you to feel your stomach go in, and I want you to use it to push all that air out. So now I'm going to give you a moment to do that on your own. I'll just ask you again to take a deep breath in through your nose and then exhale through your mouth and repeat that. As you are hopefully all feeling right now, your body is probably calming down. You're becoming less tense, your heart rate is slowing, and you hopefully are feeling more relaxed. So the reason we wanted to take you through this together is because this is a tool you have in your back pocket for the rest of your life, and it will almost always work. So it's a great strategy to use with your patients, clients, or residents that you're supporting and to guide them through. But it's also something really wonderful that we have for ourselves. And you can do this anywhere. You don't have to place your hand on your stomach and on your chest. You can just focus on deeply breathing in through your nose as you count to 4 and exhaling through your mouth deeply as you count to 4. And you can do that in your car, in the grocery store, at home, at work, anywhere you need to do it. You always have this available to you to naturally calm you down in times of stress or anxiety. So now I'm going to move on to specific phobia. So the most common phobias are animal phobia. So as an example, maybe the person's afraid of mice or spiders, natural environment. So maybe the person might be afraid of things like storms or open air or fire. Medical care. So the person might have a fear of seeing blood or a fear of a medical appointment or physicians or hospitals. And then situational. So really the situational phobias would be things like fear of public transportation or elevators or flying or enclosed spaces. Another really common phobia in older adults, however, is falls phobia. So, and this can be really common after they've had a fall, and it can lead to things like refusal to walk and deconditioning. So if you're supporting somebody who's exhibiting that, just keeping that in mind would be really helpful. And phobias are broken down into cognitive, physical, and behavioral signs. So we'll use the example of a person who might be afraid to fly. The cognitive sign would be that maybe their thoughts are, if I fly, the plane will crash. The physical signs would be that maybe when they talk about flying or try to fly, they experience things like sweating, nausea, dizziness. And then the behavioral sign might be that they either feel like they need to escape if they're on the plane, or maybe they're avoiding flying altogether. So we can apply this to all the different types of phobias. Some supportive strategies for supporting somebody with this anxiety-related disorder are cognitive behavioral therapy, exposure therapy. So when we think about CBT, just to go back, really this is the idea of working with a trained professional in CBT who helps the person sort of rewire their thoughts. In exposure therapy, a trained professional creates a safe environment that mimics the conditions that the person's afraid of to help reduce their anxiety surrounding it. And this is done repeatedly with the person. And then we know that relaxation training, meditation, and supportive counseling can also be really effective in supporting somebody with specific phobia. So thinking about panic disorder, in order to be diagnosed with this disorder, the person has to have recurrent and unexpected panic attacks. Physical symptoms can include things like pounding heart, sweating, chest heaviness, trouble breathing or feeling short of breath, numbness or tingling, fluctuations in temperature, nausea, dizziness, and feeling sort of detached. So when we look at these symptoms in front of us, a lot of these can be attributed to physical or medical issues. So you may have someone report to you that they feel like they're dying or having a heart attack. And when all medical issues have been ruled out, that's when we start to think about something like a panic disorder. And supportive strategies for panic disorder, again, include CBT, relaxation training, supportive counseling, but the most effective treatment is medication combined with counseling. Moving on to agoraphobia, a person with this anxiety-related disorder has a fear of public or crowded spaces, and we know that it worsens when the person feels like there may not be an exit strategy in place. So really, when we think about the settings in which most of us work in healthcare, the person is likely almost not going to be given a choice thinking about being in a public or crowded space. So the environment itself can be a trigger. So it's important for us to remember this as well. And then thinking about, lastly, social anxiety disorder. A person with this anxiety-related disorder has a fear of being embarrassed or judged in social settings, and fears can include large group settings, parties, or meeting new people. And for agoraphobia and social anxiety disorder, the supportive strategies are the same as GAD, which we already went through. So just a couple of resources that we wanted to make available to you that might be really useful. So the Canadian Coalition for Seniors Mental Health, the Stretch, Lift, or Tap is a really, really useful supportive strategy or tool developed by the RGP. In short, we call it SLOT. So we do encourage you to check it out. Brain Health Food Guide, the Provincial Mental Health Supports, some really good resources from Anxiety Canada about how to actually do progressive muscle relaxation with the people you're supporting. And also, there's a really useful tool about calm breathing exercises. And this will take you through it. So it actually is an audio file that you can pull up on your phone or on an iPad if you want to use it with a patient, client, or resident that you're supporting, and it'll walk you through it. Sleepwell and Headspace are also really good resources. Lots of resources surrounding meditation, mindfulness, breathing exercises, and movement as well. And I will pass it back over to Sasha.
Thank you. So we just want to kind of end the webinar with basically looking at finding the silver lining, living and working with the COVID-19 pandemic. So we hope that this webinar will allow you to reflect on the current situation and state of well-being. So allowing you to harness the life lessons you have learned going forward and how they may impact your future.
So Sasha, sorry to interrupt you. This is my mistake. I forgot to mention this. I'm sorry, everyone. This is actually a webinar that we will be presenting next month. So it's a webinar in this series coming up that we wanted to share with you in our session today because we thought it really tied into our topic. And back over to you, Sasha.
Well, thank you for that clarification. I wondered why I didn't recognize the slide. Okay, so yes, next month we will be hosting the webinar, Finding the Silver Lining, Living and Working with the COVID-19 Pandemic. And just some highlights of this webinar, it'll allow you to reflect on the current situation and state of being, We want to look at allowing you to harness the life lessons you've learned going forward and how they may impact your future. And looking at where is your personal gas gauge and what will it take to refuel from living throughout this past year and a half, almost 2 years now, hard to believe. And looking at giving ourselves permission to reconnect with our personal essence, acknowledging the impact of the past 16 months and how it has affected all of our lives. And looking at an opportunity to harness the life lessons we've learned going forward and how they may impact our future. And what will we carry forward and what will we leave behind? So that'll look out for some of the information for you to register for that webinar. And those are just some references. So we want to thank you so much for supporting persons who are living with depression and anxiety disorders and for all of the important work that you do each and every day. Questions?
Thank you so much, Tara and Sasha, for taking us through that. Really important and helpful information. There was a couple of questions about the slides and the references. So after today's session is done, you will be getting an email that actually is also going to have a short evaluation survey link attached to it, along with the slides, which includes the references in the slide deck. As well as the link to the YouTube channel. So everybody will be getting that shortly after the webinar is finished today. But we do now have time for some questions. So if you do have any questions for Tara and Sasha, please do feel free to pop that into the chat. Again, I'll remind folks to please change it from all panelists to all panelists and attendees so everybody can see the questions. Just as we're waiting to see if there's any questions from our audience today, Sasha, I'd wondered if you might be able to elaborate a little bit more about, in depression, you talked about that women tend to be more susceptible to depression. Do you have any reasons for why it is that women are more susceptible?
Yeah, so there is still a lot of research being done, but some of the main reasons is due to a lot of the changes that women go through in terms of puberty. They have some depression that's associated with their periods and menstruation. There's also things like pregnancy. So looking at, the depression that can be related to pregnancy, whether it's during the pregnancy or afterwards. As people know, postpartum is a big depression area. And then also looking at things like menopause as well. So women actually, just because of all of their natural changes that they go through, they just have a more susceptibility to those chemical imbalances and more areas of depression that they can fall under.
Okay, thank you. So let me see. Looks like we might have had a question come in. At what age are you more susceptible to depression?
At what age? To be honest, I'm not 100% sure if there's a particular age. I would say that life changes so we know that we just mentioned about women. So life changes might make them more susceptible. So I would think, so I just see in the chat, so most related to hormonal changes that all women go through. Absolutely, yes, we get the luck of the draw when it comes to that. So I would say that people are more susceptible to depression when they're going through these specific changes, especially for women. So if they're going through those hormonal changes in puberty, we are tough. That's true. If we're going through, puberty, menopause, if we're going through postpartum. So I'm not really sure about age. I just think it more has to do with some of the circumstances and those hormonal changes that happen. I'm not sure if you want to add anything, Tara.
Yeah, so I think it's really, there, to Sasha's point, it's not really, there's no age specific sort of time frame when you would be more susceptible. But I know it really does, susceptibility is something we start to think about starting in adolescence and then moving through the entire, lifespan. And to Sasha's point, it is really just, thinking about the different changes, life circumstances, life experiences, as well as we mentioned, genetics also, of course, play a role.
Yeah, and there's actually a question here related to, is there any specific symptoms of depression for young people or teenagers that we need to be more alert?
So I think if I'll start, and then Tara, if you have anything to add. So one thing that we need to understand is that adolescents and teenagers experience grief differently. So if there are some things you might want to see, you might see is that they don't really feel comfortable expressing grief to their parents or their close family relatives. So you might want to look for times of grief to see if they are kind of not expressing themselves. Again, I think they're similar symptoms, but with young people, they might actually turn to, or teenagers, they might actually turn to other more risky behaviors when they're experiencing grief. So I would look at, if you do have a younger person, just talking to them a little bit more, trying to see if you can get them to express themselves, and maybe keeping an eye on some of their social activities, because they may turn to substances or other things like that. Tara, I'm not sure if you want to pick up on that.
Yeah, no, just to sort of piggyback on that, I think, in adolescents, young adults, but even in older adults, something we need to be really mindful of is sort of like Sasha touched on, people may not be so forthcoming. And I know this question was surrounding adolescents and teenagers, but I just want to mention this because I don't think we did. Because of stigma at any age, it's really important to look at those sort of physical signs and symptoms and behavioral changes as well. Because if there is stigma playing a role, if the person doesn't feel comfortable with sharing with anyone in their life, that's where you're going to notice it first. Those behavioral and mood changes.
Thank you. And we have another question that's come through. How is genetics linked to depression and anxiety?
Good question. So what we know from our research is that, again, as we mentioned during the webinar, if there is a close relative or someone who has lived with a depressive episode or with a major depression or an anxiety-related disorder, you may be more at risk. But what's important to note about that is it doesn't mean that if there is somebody in your family who has lived with any of these mental illnesses, that you will. It's about being at higher risk, if that makes sense. Sasha, anything you want to add to that?
Yeah, so there is no direct cause and effect relationship that we can see in terms of genetics from the research that I've looked at, but it is, there was a correlation between, somebody who has close family members who have depression or anxiety, that the risk, like Tara mentioned, is higher for that genetic closeness to also experience those mental illness as well, or disorders.
We have another question that's come in. Do we have statistics in suicide attempts in people living with dementia? Aside from talking to them to determine their risk, how else can we support them?
So we don't have any statistics. I don't, Sasha, unless you do.
I don't.
Okay, just checking. No, but I think when it comes to anyone with thoughts of suicide, again, something we need to remember when we're supporting them is we have to take every sort of thought or discussion seriously. So the reason I mention that is because I know, especially with older adults, thinking about older adults in long-term care or other communal living environments, the thought may be, oh, well, they're in a long-term care home, so it'll never happen. That's not something I need to worry about. We need to worry about it every single time. And we need to monitor the person closely, and we always need to report it. Thoughts of suicide, again, just as a reminder, because I know we did cover this, never worry about asking the person whether they're vocal about it or they are forthcoming with their thoughts of suicide or plans for suicide. Never worry about asking them, because you're never going to put the idea into their head. That's really important to note as well. If somebody had the idea in their head or doesn't, you asking them the question about it is not going to cause somebody to die by suicide, or to attempt to die by suicide, or to have thoughts of suicide. So, one of the key takeaways we hope you walk away with today is asking those important questions, because, again, it's something we need to take really, really seriously.
Thank you. And just as an added note, Maria, who's also a PRC, had added in the chat around the genetic link, usually due to similar life events in families and brain chemistry. So I'll pause for a moment to see if there's any other questions from our participants today. So we've got a comment. In men, depression will show up as anger, but they often don't recognize this. Are the interventions different when working with anger and helping them to gain insight into this?
I don't think the interventions are different. Sorry, I'm just pulling up the question again to read it myself.
Sure, I'll read it again aloud too. In men, depression will show up as anger, but they often don't recognize this. Are the interventions different when working with anger and helping them to gain insight into this?
So the interventions themselves, thank you, Helly, wouldn't necessarily be different. The idea is, again, to really try to create this safe, supportive environment or space for the person to talk about what it is they're experiencing or what they're feeling. So if we're noticing, as you know, thinking of your question or your example, if we're noticing that a male we're supporting is more angry or is exhibiting signs of anger or rage or anything along those lines, I think the question we ask is, or what we say is, I've noticed you seem angry, or I've noticed your anger has worsened. Could you tell me about that? How are you feeling? And even it might even involve just prefacing it by saying like, hey, you're in a judgment-free zone. This is a safe environment. I just want to support you and I'm here to help. And at the end of the day, you can't force someone to talk. You can't force somebody to be forthcoming with the information. All we can do is really set them up in that safe and supportive environment and ask those really important questions and make those observations.
The other thing I would just mention too is that if you are experiencing somebody who is often angry or is acting in a more angry way due to a depression, I would try to find spots where maybe they weren't expressing that anger to approach them. You also don't want to increase those feelings of anger, but also looking at providing them with the information, because it's kind of like you say, they don't realize it, right? So they're not realizing that maybe they're feeling so angry because they have this underlying issue happening. So taking that time that maybe when they are a little bit more settled and say, hey, have you read about this? This is something I just wanted to let you know. Also coupling with, asking them, why do you think you're more angry? Why are you feeling more enraged? What's happening right now? Did you know that these are signs and symptoms that you could be, experiencing something else? And not to say that that will always be, something that'll work. Sometimes, like because of the stigma and because of some of the different things on gender, and men are supposed to be strong and they don't deal with depression and they don't have these, so they might have some of these preconceived notions. It might be a little bit more difficult to get through, but I think all you can do is provide them with the information and let them know that you're there to support and let them express themselves, and then they can try to do what they can with that information.
And I think it's also just important to mention, to men and to anyone, that depression is a highly treatable mental illness. And I think the reason it's important to point that out is because oftentimes that we see a lot of hopelessness in depression. And when you let people know that, hey, this is highly treatable, there is an answer, there is, a possibility of improved quality of life and mood, it may make them more likely to want to accept that help or to want to explore that path. And then I just want to circle back because our amazing colleague Maria has also gotten a stat for you, circling back to the question about stats. So thank you again, Maria. But in Canada, the highest rate of death by suicide is among men over the age of 80. And that's just a really interesting stat to share. Men are also more likely than women to die by suicide. And the reason for that is because they would use more lethal means.
Okay, so thank you again. I'm just pausing for a moment to see if we have any final questions. We have a few minutes left. Doesn't look like there's any questions coming through. So maybe I'll take us on to our next slide. So we want to again thank everybody for joining us for today's webinar. And as a reminder, I've already mentioned that you will be receiving an email with a short evaluation survey along with the slides and the YouTube link. As well as we'd like to let you know about some upcoming sessions that we have. So in August 17th, we have Managing Energy, looking at burnout. And so Sasha and Tara had already spoke a little bit about what's going to be upcoming in that session. So we hope you're able to join us for that. And then in September, we're going to be looking at design and dementia. So those are some of the upcoming sessions we have. So watch out in your email inbox for the registration information. That'll be coming to you soon. And the other thing we'd like to invite you to do is in your evaluation, please give us ideas for future webinar topics, suggestions. We're always looking for what would be helpful for folks. So please do share your thoughts and suggestions with us. I'm just going to go back to the chat box and make sure there's no other questions. It looks like we're getting some thank yous. So thank you, Tara and Sasha, for the presentation today. And again, thank you everybody for joining us today. Have a lovely Tuesday.
Thank you so much, everybody. Appreciate it.
Take
Thank
care.
you.
Stay safe.